So what am I going to be presenting today? This is going to be a little bit of an overview of CHARGE syndrome. You'll be getting much more detail about several aspects of CHARGE in later presentations. But I'll talk a little bit about where the name came from, the epidemiology of CHARGE, the genetics, and then I'll spend most of my time going through the diagnostic criteria. How do we determine that this is CHARGE syndrome and not some other condition? So I'll be talking about the major diagnostic features and the supporting features in making a diagnosis. There are many other features of CHARGE that are not particularly helpful in making the diagnosis, but can be very important for the children and individuals who have CHARGE, and I'll review those briefly. I'll talk a little bit about the sensory deficits and how they, along with the features of CHARGE, affect development in children. A little bit about outcome and just an overview of all sorts of things. As I say, you'll be getting a lot more detail about many of these things on later presentations. Most of the information that I'm covering today can be found in the paper Genetic Counseling in CHARGE Syndrome by Hefner and Fossey in the December 2017 issue of the American Journal of Medical Genetics. That entire issue is devoted to CHARGE syndrome, and so there are lots of articles in there on many aspects of it. Summaries of all the articles and links to the articles themselves can be found at the CHARGE Syndrome Foundation website, which is chargesyndrome.org. Okay, so CHARGE, where does this name come from? The name CHARGE was coined in 1981 by Pagan et al. They had just recognized this syndrome that involved many different features, and they wanted to have a way to describe it, and so they took some of the features and made it into a clever acronym. And this was C for coloboma, H for heart anomalies, A for atresia of the choanae, R for retardation of growth and development, G for genital urinary anomalies, and E for ear anomalies and/or deafness. So it's a nice name, it's great, but even back then they recognized that this acronym doesn't at all cover even some of the most important features of this syndrome. So we still use the name, but I really want to stress that we do not use the acronym features either for diagnosis or to describe the syndrome. How often does CHARGE happen? CHARGE occurs in about 1 to every 10 to 12,000 births worldwide. That may sound like it's very rare, but in genetics, we're dealing with rare conditions. And among the rare conditions, CHARGE is actually relatively common and well known now. All medical geneticists are familiar with it, and many actually have a fair bit of expertise with it. CHARGE is the most common genetic cause of deaf blindness. And by deaf blindness, I mean combined hearing and vision loss. It's a very serious syndrome that involves a lot of birth defects in many of the children, and of those who are born alive, we think that about 15 to 20% of them do not survive to age 3. The highest mortality is in those with complex heart defects along with breathing issues. And morbidity and mortality do remain increased throughout life for people who have CHARGE. A little bit about the genetics of CHARGE. The one gene that we know, CHARGE is a genetic condition. The one gene that we know causes CHARGE is the CHD7 gene, which is on chromosome 8. So this is a single gene that's on one of the arms of the number 8 chromosome. Most of the time, the changes in that gene that cause CHARGE are nonsense mutations. A mutation is a variation or a change in the genetic material in the gene, and nonsense means that it's a change that makes it so the CHD7 protein, that's the protein that's coded for by the gene, isn't working. It turns the information that makes the gene into nonsense, so it's no longer making a functional protein. Most of the time, these mutations or variants are de novo, and that's a term that means new. And what we mean by that is that the person in the baby with CHARGE is the first one in the family to have that change in the CHD7 gene. That means it wasn't inherited from either parent. It was a change that occurred usually in the sperm or the egg that went to make that child, and it's not something that's running in the family. We see this with other conditions that are inherited this way. And in these families, we sometimes see advanced paternal age, that is slightly older fathers. You may remember that chromosome abnormalities happen a little more often with older mothers. New changes in single genes happen a little bit more often with older fathers. Once a couple has a child with CHARGE syndrome, there is a small but increased risk of having another child with CHARGE syndrome. That risk is about 1 to 2%. So it's higher than that 1 in 10 to 12,000 in the general population that I mentioned previously, but it's still a 98, 99% chance it will not happen again. Once someone has a gene for CHARGE, it's inherited as an autosomal dominant condition. That means that it can be passed on to the next generation. You probably remember that everybody has 2 copies of each gene, one from the mom, one from the dad. If someone has CHARGE syndrome, they have 1 CHARGE gene and 1 normal CHD7 gene, and it's 50-50, a flip of the coin, whether they're passing on the CHARGE gene or the normal CHD7 gene to each child. CHARGE is extremely variable in its expression, and that means if it happens more than once in a family, it's not necessarily going to be the same in the 2 affected individuals. You can see this picture of identical twins who have CHARGE. Their genetics, their DNA is identical, but they have different heart defects. One of them needed a tracheostomy, the other one didn't. So they're not identical in how the CHARGE is showing up in each of them. The family that you see here in all white on the beach, their oldest child, who's sitting on the sand, has CHARGE syndrome. The middle 2 children don't have CHARGE syndrome, and the baby in the mom's arms does have CHARGE syndrome. So this was a recurrence. Neither parent has it, but it was a recurrence in the family. This family has actually gone on to have a 5th child who does not have CHARGE syndrome. So, but again, the 2 boys in this family who have CHARGE have slightly different features. We've also seen people who've been diagnosed with CHARGE, a parent who's been diagnosed with CHARGE because they have a child who has more typical CHARGE. So in those situations, you have a child who's diagnosed with classical typical CHARGE syndrome, and you look really closely at the parents and you realize, oh, he's got a hearing loss. Maybe he had feeding problems when he was a baby. Maybe he walked late because he had balance problems. And when you do the testing, you find out that he carries that same gene, but it was never brought to medical attention because the problems weren't as severe. So it's extremely variable expression and does not run true in families. And this is a family that we found in Missouri who has 3 generations of individuals with CHARGE. And the grandmother on the top and the mother in the middle both had relatively mild CHARGE. They did well enough to be able to get married and have children and do well in life. The young man on the very bottom row had very typical CHARGE, needed lots and lots of care. His sister was much more mildly affected. At that time was in high school and working at a fast food restaurant. They also had 2 sisters who did not have any features of CHARGE, and their mother had a couple of babies who died in the newborn period of severe birth defects who probably had CHARGE with more severe birth defects. So the 3 generations of affected individuals in this family had different features. I told you before that we don't use CHARGE to make a diagnosis of CHARGE. So how do we make a diagnosis? The diagnostic criteria for CHARGE have evolved over the decades and are still a little bit different. Every clinician does things a little bit differently, but for the most part, we use major features and supporting features. So when we have individuals who have multiple birth defects and problems, the question is, how do we distinguish between one syndrome and another syndrome? So the major diagnostic features are those which are common in CHARGE, but relatively rare in other syndromes, and ones that are recognizable early in life, so that we can make the diagnosis in babies and children rather than later on. Supporting features can be any number of things. Sometimes there's things that are very significant and very common in CHARGE, but also common in other syndromes, so they're less helpful in distinguishing is it CHARGE or one of the similar syndromes. They may be things that are significant when they're there, but they're less likely to show up. Or they may be things that are actually unique to CHARGE, but either difficult to diagnose consistently or have later onset. So the clinical diagnosis is still the gold standard, and we do it with major features and supporting features. What are these major features? Well, instead of CHARGE, I sometimes refer to the major features as the 5 C's because I could get them into things that all start with C. And that is coloboma of the eye, choanal atresia or cleft palate, cranial nerve anomalies, characteristic ears, and CHD7 pathogenic variant or mutation. A pathogenic variant is the term that in genetics we have evolved to talk about what we previously referred to as mutations. They're changes in the DNA. Those terms are fairly interchangeable. And the genetic counseling paper that I mentioned earlier on has a table that includes a differential diagnosis. And that is, what other syndromes have features that overlap with CHARGE, and how do we distinguish between them? So you can look at that paper to see what other ones look a lot like CHARGE and what we're thinking of in any child that's being evaluated for possible CHARGE. The supporting features include congenital heart defects, problems with the trachea or esophagus, renal kidney problems, genital problems, typical dysmorphic features, especially the face, sometimes facial clefts like cleft lip, brain anomalies, growth retardation, including sometimes growth hormone deficiency, and behavioral characteristics, especially obsessive compulsive disorder and autistic behaviors. I'm going to now go through some of the major features in much more detail. And you need to have at least 2 of the major features to have a definite diagnosis of CHARGE. And by the same token, if someone has any 2 of those features, they should be evaluated for possible CHARGE syndrome. The first of these features is coloboma of the eye, and about 80% of people with CHARGE have colobomas. This can be in the iris, the retina, or the macula. What is a coloboma? Well, when the eye is forming, the eyeball forms and it comes around and it kind of zippers closed along the bottom. And if there's a problem with that zippering closed, if there's a gap in the zipper, you're going to end up with a coloboma or a cleft in the eye. And it can happen anywhere from the front of the eye to the back. If it happens all the way in the front of the eye, it's an iris coloboma, and that will give you a keyhole-shaped pupil or a notch in the pupil that extends down through the iris, as you can see in this picture here. An iris coloboma doesn't affect vision, but what it does do is affect your reaction to light. Normally your pupils restrict in reaction to very bright light so that you can go outside in the sunshine and not be bothered by it. If you can't constrict your pupil all the way, bright lights may bother you a lot, and a lot of these kids want to wear tinted sunglasses, maybe even indoors, and are very sensitive to light. If the coloboma happens farther back in the eye, that's in the retina, and that would be a retinal coloboma, and that's going to cause blind spots, visual field defects. And this picture of the retina here shows a lot of red area where there are a lot of blood vessels, and in the middle there's a big white glob. That's the coloboma, where there's a gap in the retina. And what that's going to do is give you a visual field defect. When there's a coloboma in the retina, it's going to be in the bottom part of the retina. And if you remember, your vision gets flipped, so something in the bottom part of the retina is going to affect your upper visual field. And this drawing is an actual visual field of a 16-year-old with a retinal coloboma. If you see a visual field drawing of someone who has normal vision, it's going to be round with a little blind spot. We all have a little blind spot in our retina where the nerves come together. You can see in this drawing that there's a big cut out of the upper field, and he's got a visual field defect up here. It's as though you're wearing a cap with a bill pulled down. You're not going to see anything up above. So what do kids do with that? How does that affect them? Well, they put themselves in positions where they can see things. So these kids will often be sitting and using the lower part of their visual field to see things that are up above them. When you're little, most everything is up above you. They may get upside down. They sometimes get in very unusual positions to use the vision that they have. And I think something that's important to think about, we talk about visual loss. It's not really, it's a difference, but for them, it's not really a loss. If I suddenly developed a coloboma, it would be a loss for me because I'm used to having this vision up here. They're used to not having it. And so they just accommodate and get into position so that they can use the vision that they have. It's just like I don't have eyes in the back of my head. So if I want to see something behind me, I'm going to move and move around so that I can get to where I can see what I want to see. So they don't have that, they move there. The problem comes in with everybody around them who expect them to have vision up there and present them things to them up here and don't realize that they're not able to access that information. They're not able to see it. Another thing about colobomas is the coloboma can be in the macula. That's the part of the retina that's responsible for central vision. And that will give you a central vision loss. And that means that you're going to need to use your peripheral vision down low and around the side to see things. So if someone has central vision loss, they're going to be using their peripheral vision, and it's going to appear that they're not making eye contact with you. They may be paying very close attention to you, but it doesn't look like it. The young lady in this picture also has a bilateral facial palsy, and that, which we'll talk about a little bit more about in a minute. And that means that she's not able to animate her facial muscles. It's a very bland expression. She can't smile. Her eyes are wide open. And if someone has central vision loss and bilateral facial palsy, it looks like they're looking off to the side and they're not paying any attention. And that may not be the case. They may be paying very close attention to you. So it's really important to understand what's going on with both the face and the vision to be able to understand what they are actually paying attention to. The second of the major diagnostic features is choanal atresia. And about half of all individuals with CHARGE have this. So it's a little bit less common, but when it's there, it's very helpful. The choani are the passages from the back of the nose to your throat that make it possible for you to breathe through the nose. Atresia means blockage. Stenosis means narrowing. Bilateral is both sides. Unilateral is one side. So you can have a blockage or a narrowing on one or both sides of the nose. And for diagnostic purposes, those of us who've been involved with CHARGE for decades have agreed that cleft palate can be substituted for choanal atresia. About 20 to 30% of people with CHARGE have a cleft palate. Embryologically, those are different things, but from a diagnostic point of view, you can use either one of them. So what does choanal atresia do for you? Well, if you have blockage of the nose, that's really, really important. Newborn babies are obligate nose breathers. If they can't breathe through their nose, if you don't prop their mouth open and force them to breathe through their mouth, they will suffocate. And I think this probably developed so that babies could breathe and eat at the same time. But it's a really important thing to know about early on and to fix and to manage very early. What they do for this is they surgically open it up, and this requires doing surgery, putting in what's called a stent. It's sort of a straw that stays in there, keeps it open while it heals around it, and it sometimes starts to close down, and they need to dilate it to open it up again. Children with charge sometimes need multiple surgeries and multiple stent placements to keep it open for a long time. If someone has just a unilateral stenosis, that is a narrowing only on one side, that can be really hard to diagnose, because the only way you can diagnose stenosis is to stick different sized tubes up their nose and see what goes through. It's a very unpleasant thing to do to a baby, and so we often don't do that unless they're under anesthesia for some other reason. But a stenosis can still be important because it can cause a lot of ear problems and sinus problems and fluctuating hearing loss. So there can be consequences to that as well. So it's very helpful to know, even if it's just a narrowing. The third of the major diagnostic features are the cranial nerve anomalies. And this is a whole set of features. And if we take all of them together and say who has at least one of these, more than 95% of people with charge have some kind of problem with at least one of their cranial nerves. And these can cause problems with facial palsy, feeding problems, anosmia, that is no sense of smell, and sensory neural hearing loss. Facial palsy is cranial nerve number 7. You remember that picture I showed you before of the young lady with a very bland, no facial expression? She has a bilateral facial palsy. So the facial nerve animates the whole side of the face. So when you smile or when you cry, your ears squinch up, your mouth smiles, your cheeks get lines in them. That whole thing is from cranial nerve 7. If you have a one-sided or unilateral facial palsy, you'll have a very lopsided face, especially when smiling or crying. If there's a bilateral facial palsy, there's no facial expression at all. And a bilateral facial palsy can also interfere with sound production, so speech may be even more difficult to understand beyond what you get from the hearing loss. The young lady there that's pushing her cheeks up, she knows socially that her mouth is supposed to change when she's smiling and she's happy, and so she's making it do that because her face won't do it all by itself. There have been children or people who have had nerve transplants where the doctors take a nerve from the leg and transplant it into the face to try and reanimate the face. That's been done successfully. It's not routinely done. And to illustrate really more dramatically, the young lady with the bangs there that's smiling, I took her picture. You can see her picture on her there, and I made a double right side and a double left side. So you can see the side that has the facial palsy, you can sort of tell that she's trying to smile, but her eyes are wide open. The smile sort of doesn't reach her eyes, and it's pretty bland. It looks like a fake smile. You look at the side that does not have a facial palsy, and you can see that the smile reaches the eyes and her cheeks and the whole thing. So you can really get a feel for how that would look if she were symmetric either way. Another cranial nerve anomaly are cranial nerves 9 and 10. And these are the cranial nerves that coordinate, suck, and swallow. And this is a very complicated system. And I'm not going to go into all the details, but just know that the swallowing problems are severe enough that, and 70 to 80% of people with charge have issues with this. Many of them end up with gastrostomy tubes, where they have a tube that feeds them directly into their stomach. These issues usually get better over time, but it may last for years, and there are still some adults who are still fed by gastrostomy tube because they're not able to take food by mouth without choking or getting it into their lungs or things like that. And many of the adults with charge have told me that they still avoid certain textures because they have trouble getting them with the chewing and sucking and swallowing, and choking remains a possible hazard for even adults with charge. Other complications that go along with the swallowing problems is aspiration. If instead of going down the esophagus, food is going into the trachea and getting into the lungs, that's aspiration. And aspiration pneumonia is a very common cause of hospitalization in children with charge. Gastroesophageal reflux is very common. In addition to surgery to put in a gastrostomy tube, many need to have sort of the top of their stomach tied off so that things doesn't go up and down the esophagus. So oftentimes need a lot of surgical management for that. Getting kids to eat orally can take years and lots of therapy. The last cranial nerve I'll talk about is cranial nerve number 1, and that is the sense of smell. And this is very, very common in charge. It's really difficult to test for sense of smell in children, but the best tests that we have for charge say that half of the children with charge have no sense of smell at all. The other half have a decreased sense of smell. So having normal sense of smell would be extremely uncommon in people with charge. And you think about smell, the sense of taste in charge is probably normal or near normal, although we haven't specifically tested that. But most of what we refer to as taste, or maybe flavor is a better word for it, is actually smell. And if you think about when you have a cold and your nose is stuffed up, food tastes really bland because all you're tasting is sweet, sour, salt, bitter, the stuff that you taste, not the stuff that you smell. And so that further complicates getting these kids to eat orally because it's not very pleasant, there's not much reward to it, and so on. In addition to issues with feeding, lack of a sense of smell has some safety implications. Think smoke, spoiled food, that kind of thing. One young woman said, who lives completely by herself, said, well, I just put dates on my leftovers, and after a certain amount of time, I just throw them away because I can't smell it until if it's gone bad. There are also social implications for no sense of smell. Think smelly feet, body odor, passing gas. One young woman I know was a resident at the School for the Deaf. She was a teenager. She had a lot of issues with passing gas. She couldn't hear it. She couldn't smell it. She could feel it, but she had no idea that other people around her were aware that this was going on, much less that it was unpleasant for them, that it smelled bad, that it was a not nice experience for them. She had to very specifically be taught, when you feel that, other people are smelling something that's very unpleasant. And since she doesn't smell at all, that was a really hard concept to get across to her. That's some of the incidental learning that I'll mention later. You usually don't have to teach kids about that. They figure it out by how other people react and by their recognizing things. Well, if your experience of the world is different because you're not smelling things, you're not going to understand the reactions of other people. So the lack of sense of smell may not seem like a big deal, but from a social standpoint, it really can be.